Hello, my name is Dr. Ajayi Satibo, and a little bit of an introduction. So I'm a medical doctor. I work in NHS and as a private GP, and I also run a platform called Mind Body Doctor, which is all about trying to encourage people to understand their health more and want to take control of their health. And over the past year, I've been doing a lot, and I've had a lot of interest in really the disparities that we've seen, especially in terms of COVID and how it's been affecting the Black and Asian community compared to their white counterparts. So that's really what we're going to be delving into today. And I have the amazing Dr. Zubaida Haque joining me today, and I'll just pass the mic over to Dr. Zubaida, who can introduce herself.
Hi everybody, thank you for joining us. My name is Dr. Zubaida Haque. I'm a member of Independent SAGE, a scientific advisory group for emergencies, the independent one. If you haven't heard of us, we were pulled together last year, and there's about 13 of us. And the reason we came into existence is because we felt that the government wasn't being transparent about the science behind this pandemic. And what we wanted to do is advise the government as well as the public, as well as share the science behind this pandemic with the public so that everybody could see what was going on and have a better understanding of this pandemic. I'm also the former interim director of the Runnymede Trust, which is a national race equality think tank. I was there for 4.5 years. And essentially what Runnymede Trust did was we looked at gaps between different ethnic groups across all public sector areas, and we carried out research and public policy in those areas, and where necessary, campaigned with government to address important gaps, including, for instance, the Windrush scandal. So, back to Tosin. Let's start, shall we?
What an introduction. Thank you very much. I mean, it's such an honour to have you here and to be able to really pick your brain and hopefully, for myself as well, learn more about what's happened over the past nearly couple of years. So I'm excited to delve into the conversation. Now, COVID has really shaken the world in so many ways. And I think one way in particular is just how it's affected some communities and the disparities that we've seen between the Black and minority ethnic communities compared to the white communities in the UK and also across seas as well. So just to read out some statistics, the Public Health England report last year reported that Black people and men of Pakistani and Bangladeshi heritage were twice as likely to die during COVID, and this was during the first wave, compared to their white counterparts. 21% of all staff are from Black and minority ethnic groups within the NHS. However, 63% of staff that passed away within the first wave were from those groups. So really big disparities and inequalities that we're seeing within these figures. And I've spoken to lots of people and I'm getting lots of different answers as to why we saw these numbers and why we saw these inequalities. And I think there's no right answer, at least there's no one answer. And do you have a view, Dr. Zubaida, on why we were seeing these inequalities?
Well, I think there are lots of reasons. I mean, as soon as the pandemic started, at that time I was still interim director of Runnymede Trust, and I knew almost straight away, as did most of my colleagues, as did many organisations in the third sector, that this pandemic was going to hit Black and ethnic minority communities disproportionately, and it was going to hit people in deprived areas disproportionately. And the reason we knew that was because those pre-existing inequalities had been there, and they'd always been linked to health inequalities. They were strong predictive factors of health inequalities. But what was astonishing, Tosin, was that there was hardly anything said about it. So, it's March, April, very little was said. But we thought, we were all quite afraid of what might happen. So almost immediately, at the Runnymede Trust, I started to talk to lots of people, started to write articles and talk to journalists and say, listen, we need more data, because at the moment there's no data coming from government, from the NHS, that has any kind of ethnic breakdown, and we need an ethnic breakdown in this pandemic. And lo and behold, after much, if you like, sort of lobbying, really putting pressure on government NHS to carry out an ethnic breakdown of COVID-19 illness, of COVID-19 mortality, we could see that there were huge disparities, huge inequalities between Black and ethnic minority groups and their white counterparts. In terms of the reasons, there are so many. I'll leave it there. Perhaps you want to ask me more, but there are so many reasons why. But it wasn't a surprise, which doesn't take away from the fact that it was still devastating to see those inequalities when they appeared.
Yeah, I think it's really interesting to hear you say that, yourself and your colleagues, you kind of foresaw this coming. You knew that it was going to hit certain communities worse. Whereas the rest of society, the rest of the community, it was a shock to most people. And why, is there a reason, or why do you think, the average person in the community wasn't aware of actually just how badly it could affect those communities?
That's a really good question, Tosin, and I think it does raise the question of why we didn't talk much more about health inequalities, or why it wasn't on the national radar, because in that sense it really wasn't on the national radar. And this was despite the fact that we had the Marmot Review 11 years ago, highlighting the inequalities, and last year we had an update 10 years later of the Marmot Review, which showed that not only did health inequalities exist, not only were certain groups hit much more than others, certain communities, Black and ethnic minority, Black and Asian communities, women, Black and Asian women, but also, people living in deprived areas, and particularly very deprived areas, their disability-free life expectancy had shortened. And that was really concerning, particularly of women. And hopefully we'll talk a bit more about women, because I do feel that they've been one of the most invisible groups in this pandemic, ironically. But it was, I think it's because health inequality just wasn't on the national radar. And yet, health is critical to absolutely every aspect of our life: our ability to work, our ability to go to school, our ability to bring in income. Health underlies all of that. So in a way, I suppose it's one of the sort of mixed blessings from this pandemic, that now we are more acutely aware of not only health inequalities, not only the fact that we're not all in the same boat, exposed in the same ways, but also that we need to do something about it, that there are wider factors, more than biological factors, that determine our health outcomes.
Yeah, no, I think you're completely right. I think, there's been long-standing inequalities, like you said, and all COVID did was really just bring those inequalities to the forefront and shine a light on it. And unfortunately, it took a pandemic to do that. And unfortunately, we had to lose lives, and people became unwell, and it affected so many lives in more ways than others. But unfortunately, there is a little bit of a blessing in it, in that actually, as a society, we are more aware of the inequalities, and hopefully this is pushing our government and the heads that be above to actually make some changes, and to actually wake up and say actually something needs to be done about this. We hope.
Well, yes, I was going to say I wish I could have the same optimism. I think you're absolutely right, Tosin, that this is an opportunity. This is a once in a life, once in a generation opportunity where we can look at the health inequalities between different communities and ask, can we do things better? Because we don't want to go back to the old normal. We want a new normal where people, where we know that there are ways that we can address health inequalities, and we do something about that. I think where I feel a bit pessimistic, or at least I worry, I worry, is that it was patently clear from all the data that came out in the first wave of this pandemic that there were inequalities between the ethnic groups, where Black African, Black Caribbean groups were much more likely to die. Like you say, you know, it was sort of actually 2 to 4 times likely to die compared to their white counterparts. You know, around 4 times for men, around 3 times for Black women. And for Asian groups, you know, it was somewhere between sort of 2 to 3 times more likely to die compared to their white counterparts. We were aware of those statistics, and we were aware of those, even though ethnicity doesn't feature on our death certificates, which is another issue. I mean, that's another issue altogether about how much more we need to do in terms of achieving, you know, race equality outcomes. But we were aware of that. The government published, after much pressure, about 3 reports looking into why we had disparities between the ethnic groups. There's a lot of research done and a lot of fanfare about it from Boris Johnson. But what happened in the first wave, in the second wave, was that things got worse. In the second wave, things got worse, certainly for Bangladeshi and Pakistani groups, where the gap between them and their white counterparts in terms of mortality, in terms of more likely to end up in ICUs with COVID-19, widened. Now, at the same time, the gap slightly narrowed between Black and their white counterparts in terms of mortality with COVID-19. And I can explain why that was. But the point is absolutely nothing was done to reduce the risk. The same for people, you know, the same for people in deprived urban areas. The government knew what the risk factors were. The government knew that things had to be done, particularly around supporting self-isolation. You know, we know that Black and ethnic minority people are much more likely to be in occupations where they're not necessarily likely to qualify for sick pay. They're not necessarily likely to qualify for the £500 benefit, which was ridiculously high in terms of the criteria to apply for it. And also you needed to be in benefits. So many millions of Black and ethnic minority groups didn't qualify for self-isolation, which meant that if they were at risk or if they'd been in contact with a positive case, they had the very difficult choice of either choosing to go to work or choosing to stay at home but with no income. And that was an impossible choice, but the government did absolutely nothing about that. So in that sense, I guess I feel a bit more pessimistic that the government has learned from any of the reviews that it did last year.
I think, you know, and rightly so. I'm glad you shone a light on some of those things that actually some of us don't realise or we just take for granted. I think we put up with a lot in our society. And actually, when you sit back and here you say, no, actually, when you think about it, there could have been a lot done in between those 2 waves to help those communities that the government knew were going to be hit again the hardest, but nothing was done. So, I mean, sadly pessimistic, but I can completely understand. And you mentioned that the gap during the second wave, that the gap between Black groups and their white counterparts lessened when it comes to mortality. But
still
the
high.
gap between it was still high, but it was less than the first wave. And the gap between South Asian and Pakistani groups actually widened. And that's really interesting. Any thoughts on why you think that might be?
Yes, I think if anything, it highlighted how the risk factors for Black and Asian groups in this pandemic wasn't necessarily biological, that it was much more social, economic, the types of jobs that they did, the types of housing that they lived in, multi-generations living in the same households, overcrowded households, inner city areas where risks were much more higher. The fact that a higher proportion of, for instance, Black African people were working as key workers in the first wave, while Bangladeshi and Pakistani people, who were much more likely to be in different occupations, for instance, catering and so on, of course, because of lockdown, were shielded much more in the first wave. So that made sense when you saw that Black African and Black Caribbean groups, who were much more likely, because of the types of jobs that they had, much more likely to be exposed to this virus. And on top of that, of course, we had, if you liked, other issues such as intersectional issues such as poverty. We know Black groups have extremely high rates of poverty, just like Asian groups, types of housing they lived in. But because of that exposure, Black groups were much more exposed in the first pandemic. But in the second pandemic, in the second wave, sorry, not in the first pandemic, the first wave, in the second wave, that's slightly reversed in the sense that Bangladeshi and Pakistani communities had to go out to work much more. Of course, the restrictions, if you like, had lowered. The restrictions had lowered much more, so people could go out to work. There were many more exemptions. Takeaways opened, restaurants opened, the types of jobs that Bangladeshi people were doing. They were all back to work, but they were also all back to work because of the economic necessity of going back to work. One of the other things that we know from this pandemic was that Black and ethnic minority groups were hit much harder economically compared to their white counterparts. They were much more likely to have lost hours, wages, much more likely to be furloughed, much more likely to have just lost their jobs, particularly young Black and ethnic minority people were much more likely to have lost their jobs. So you can see that pressure would have built up as the pandemic wore on to go to work, to expose yourself much more to this virus. We also know on top of that, because of racial discrimination, that for instance, particularly in the first wave, that Black African people and Black Caribbean people were less likely to get PPE compared to their white peers in the same jobs. We know that, we've seen the research. So all of that together amounted to being overexposed to this virus, but also underprotected. And they were underprotected economically, and that mattered because they couldn't afford to self-isolate. That mattered because they were going out to work when others could stay at home, and that mattered because they were having to take public transport, which we know also enhances the risk in terms of transmission of the virus. So it was that perfect storm of factors, and at the same time, Tosin, I feel things are going to get worse. So I shouldn't be saying this. I don't want this to be a depressing conversation. But right now, I'm acutely aware that children in schools are being exposed to this virus, that the government are carrying out a mass infection experiment with our children in schools. And right now, 1 in 20 secondary school children are infected with COVID. Now, 1 in 20 are missing school, and that excludes their close contacts. So actually, it could be much higher number of kids with COVID right now. Now, that's a phenomenal amount of infection with young people, let alone the educational disruption that we were promised that wouldn't happen. But we have to remember, a third of the children in primary school, actually more than a third of children in primary school, and about a third of children in secondary school are from Black and ethnic minority groups. So when you carry out a mass infection experiment on school children where there are no mitigation measures, no safety measures in schools because the government decided to lift them all, including face masks, which is the easiest safety protection measure you can have in terms of COVID, the least intrusive, if you like. When you lift all of those and you know that, COVID transmission rates in the community are very high at the moment. At the moment, it's about 37,500 or something around that, 35,000 per day cases. And you do it with a population that's largely unvaccinated. Only one thing can happen. Children, there's no choice for children. They were being infected deliberately. But it is Black and ethnic minority children, once again, are disproportionately at risk. Once again, they're going to be taking it home to families that we've known that are also much higher at risk. So actually, Tosin, I'm very upset about this, and I'm really angry. I'm really angry that the government is doing all of this without carrying out any equality impact assessment at all about the devastation that it's going to bring to these communities.
I agree, and I think I'm going to ask you possibly an impossible question to wrap up, but you've spoken about so many different factors of inequality that has impacted the numbers that we've seen: health, employment, economic status, and just how large that impact was. And really, like you said, it's a matter of life and death. How can we move forward from this? What is the next step? Difficult question, and I know there's not one answer, but what would you say to that question?
I'm glad you didn't ask me for one answer, because there's absolutely not one answer. It is multifactorial. I mean, look, we need to start where we started with this pandemic, which is, and I know this is a boring thing to say, but data. Because if you don't have the data about the inequalities between among Black and ethnic minority communities, really important to disaggregate between the different groups, but also between them and their white counterparts. If you don't have the data that shines a light on where those inequalities exist, then you won't get the policy to address it. It's as though the problem doesn't exist. So you need the data to show that the problem exists, which means that then the politicians, the policymakers will address it. So that's where we start. But actually, then we need to address all the social determinants, the social, economic, housing, educational, all those determinants which influence health outcomes. And we know what they are. We know what they are. We know how to address them, because we have had report after report after report, reviews after reviews after reviews, telling us where those inequalities exist, what we need to do. Housing being an essential one. We know that Black people, we know that Black and Asian people are much more likely to live in overcrowded housing where there are more adults than rooms. Now, in this pandemic, that was devastating. That had a devastating impact because it meant that people couldn't self-isolate safely. There was no room. The government didn't offer, like other governments across the world, other accommodation for you to self-isolate. They didn't offer any income to self-isolate or anything. So, we need to address those issues. But we also need to address the fact that one of the key reasons why Black and ethnic minority groups were more exposed was because they were much more likely to be poorer. They're much more likely to live in deprived communities. And we know that poverty and deprivation is highly linked to health outcomes because of what you can afford, because of the type of house that you live in, because of how much heating you can afford, because of how much food you can afford, because of having to take public transport when you shouldn't necessarily, be taking it because it's more risky, because of all of those reasons, from diet to the types of jobs that expose you more. For all of those reasons, we know income matters. And yet, we are going the wrong way. Just today, the government has completely taken away the £20 uplift in universal credit that families were relying on. And we know that Black and ethnic minority families disproportionately rely on universal credit. And in the pandemic, it was also many more Black and ethnic minority people had to turn to universal credit because they were much more likely to lose jobs or have fewer hours, less income, and so on. So we need to address those. And so I suppose in that sense, that's why I was saying it's not, there's no single magic bullet. It is addressing all of those issues. And it's having a cross-government strategy. Because unless you have a cross-government strategy that addresses issues of racial inequalities, you're not going to get that systemic change. And we've always known that. So it requires a government to go beyond rhetoric and to actually implement some of the policies that their own reports have recommended.
I mean, definitely not one answer, but I think you've given a pretty great answer to some of the obstacles that we need to tackle to be able to move forward. And I guess for me, just to add on to that, I think it's also people like yourselves, people that are actually bringing voice to these inequalities and speaking about it and actually saying, hey, this is actually what's happening and we need to do something about it. So thank you so much, Dr. Zubeida Haque, for coming to speak to us today. It's really been amazing. I know that I've learned a lot. It's a difficult but important topic of conversation that I hope we keep speaking about more. And I hope, it doesn't, like you said, it's the acute phase of things. We're still in it. We're still in the pandemic. And, we're talking about it, but still not enough. So what's going to happen moving forward? Is it that we're going to stop talking about it? Is it going to slowly die out? And I hope that's not the case. But thank you so much for coming to speak to us today. And it's been a pleasure.
Me too, Dr. Ajayi Sotubu. It has been an absolute pleasure to meet you. Hopefully we can carry on these conversations and hopefully our paths will cross again. Thank you. Thank you for having me.